87% of the patients had positive nodes, and you can see the 3-year local regional control rate is over 90%, and overall survival 88%. Now, is this unique to a large center? We addressed that within the RTOG. So this is a multi-center study, started in 2000, and you can see there were 67 patients enrolled from 14 centers, and 3/4 of the patients at T2, and about half N1. And although this is a little bit early, you can see that the local regional control has been very high, and so far we have not encountered metastatic disease or second primary. And I think the 30% you mentioned, Dr. Glantz, is overall, but most of them come in the lungs and the esophagus. So as far as that second primary, in the head and neck region, it's probably about 10% or so. So I'll stop there. So I think in the next discussion, perhaps, Dr. Shah, we may consider a stage 2B because of these differences in outcome. So I'll stop there for my remarks.
Okay, thank you very much. I just want to briefly go into the discussion of the locally advanced disease and the options we have there. We all know we have the altered fractionation regimens, we have chemoradiation with different regimens, and we have the targeted therapies. And just a short view of the panelists here, what would you advise on locally advanced? What is your regimen you use on a daily routine? Kian, first of all, and then the others.
I think outside the protocol study setting for other stage 3 and 4, so I'm not talking about small t and small n, I consider concurrent radiation and cisplatin as the standard. But we do offer other options to the patients, and the other options are radiation plus cetuximab or TPF followed by radiation. So I think you need really to discuss with the patients, talking about the data and the toxicity profile. And some patients will choose cisplatin, concurrent cisplatin, some will choose cetuximab, and some will choose TPF.
The question is, as we are head and neck surgeons, we would consider first a surgery, but if the surgery is too mutilating concerning the functional outcome and combined to a reduction in quality of life with a persistent PG and so on, our aspiration maybe even if the base of the tongue is too much involved, especially in these endophytic lesions, then we always would consider, if possible, if the patient's general status is able to do this, we would indicate after a conference with our radio-oncologist, we would indicate a concomitant chemoradiotherapy. But my impression is that in the in-between lesions, this is a bit of as you mentioned, is the T2 lesions. This is a very difficult and inhomogeneous group of patients and tumors. You only have to have the host and the tumor. Then it's it depends. If the tumor is extraphytic, and even in advanced stage, I would prefer, if it's possible, a surgery in combination with radiotherapy, and because the lymph nodes are normally involved. But if the lesion is undifferentiated, it's diffused, and then I think that's the best thing to do is concomitant to chemoradiotherapy. either this or that. This is a question of experience and of a method. But my impression is that the therapy is too slow in effect, and if you have an advanced disease, distant metastasis is much higher than in the lower stages. And you are not able to get the distant metastasis even with systemic chemotherapy, which you use. But this is, I have to check the numbers. Even retrospective data can tell you something. If you remove the tumor, you remove the enemy, as Barbara Wallenberg said, the other enemy we don't yet know. You remove him totally. So I think this might be a better chance. But sometimes it's not good for the patient, and these options, as we have shown in the oropharynx, are really a better option than we had before.
Jerry?
Yeah, well, as I'm giving a few comments, can I have my last slide put up to just the final one? One of the things I think that's important when we look at advanced oropharyngeal cancers, I look at this as a spectrum. There's no question that the definition of advanced becomes very blurred because obviously most oropharyngeal cancers are going to have a high incidence of neck metastasis. So right away they're going to be stage 3 and very often they're going to be stage 4 disease. And a lot of people will say automatically a stage 3 is an advanced tumor. That said, if we're talking about the size of the primary tumor is such that I feel that in terms of the resection of that primary tumor, I think there's going to be significant compromise of the individual's function. Those are individuals that I clearly want to ensure that they've had a very in-depth discussion with my medical and radiation oncology colleagues, because very often those are the patients that I'm going to recommend that we have upfront chemotherapy, radiation therapy and targeted therapy, whatever they choose. That could be predicated upon the primary tumor. It could also be predicated upon extensive neck disease, and it would depend upon the individual. So the corollary is it's almost a spectrum. Smaller lesions, no question at all I'd recommend having surgery because I think there's going to be no morbidity or functional deficits to doing them. It's kind of like somebody who comes in and says, I have an unknown primary and I find a little cancer in the tonsil. I've seen people who go in and do a tonsillectomy, find the primary and say, well, I'm not going to operate on it now, I'm going to send them for chemoradiation. I mean, one little bit of muscle around that tonsil and you've done a curative operation and they abandon it. It just drives me crazy. I don't understand that at all. The second thing is that as the tumors extend in terms of size, either in terms of palatal dysfunction or tongue-based dysfunction, I think those are situations where oftentimes you get into a blurred zone. Are you going to do surgery or are you going to do radiation and chemo? And then as they get larger, radiation and chemo. And finally, when they get to be very extensive tumors that are involving mandible, extending down into the larynx, where I know that these are going to be rare cases, I'm going to have to do a total glossectomy, total laryngectomy to do it. Those are individuals I tell my patients, I'm sorry, you've got such an advanced tumor that now I'm afraid you need all 3 forms of treatment and we better operate first. You better have radiation, you better have chemotherapy. So I think that if we're going to have any chance to get people well for these extensive, massive tumors, we're talking about all 3 forms of treatment. Can I have my last slide up, please, then? If it's available there. The final one. Well, just a couple points here. I just wanted to point out a couple things. As I mentioned, I really don't see a functional benefit to preserving a tonsil or half of the tongue. There was a major national cancer database study that was presented in 2004. Looking at thousands of cases across the United States in the National Cancer Center database. And if you looked at those individuals, and they're stratified there, you can see how many patients were in each group. Over 2,000 in the surgery group, 3,000 in the radiation, 4,000 in surgery and radiation, over 2,000 in radiation and chemotherapy. And if you look at what happened in the stage 1 and 2 and stage 3 and 4, 5-year disease-specific survival groups, you can see that still the best results were generally coming into the surgery and radiation therapy for the advanced stage 3 and 4 disease. Luis Kowalski just presented last year a very extensive series coming out of Brazil, an individual who I trust very much in terms of his data. He again found surgery and radiation to be higher. And the last bullet on that is a series that we are presenting now at the meeting in San Francisco, looking at 102 patients who had, this is just tonsil cancer. We're presenting separately our tongue-based tumors that were done transorally. But these were transoral removals alone. The vast majority of them, again, are stage 3 and 4 because of neck disease. And our 5-year local regional